Hello. Hello.
Yes. The
Yeah.
meeting started.
Yeah. Yeah. I'm here. I'm here.
Nilesh?
Yes. Yes. I'm here.
Is it Nilesh? Hello?
Yes. 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 Yeah.
Okay.
Yeah. Nilesh here.
Okay. Okay. No, there was a lag, some internet connection.
Yeah.
Yeah. Yeah.
Yes. So you have the PPT for the introduction, ma'am.
No, it's just this that I have.
So should I share?
Yeah.
Okay. So should I share my screen?
Yes, please.
Yeah.
You would want to? Then I can
Okay.
stop.
Okay. Yeah. Yes. Yeah. I think you need to enable my screen sharing, ma'am.
Okay. Do you want to send me?
Sorry.
Just a minute. Do you want to send me through email?
Uh, yeah. I can send you now.
Yeah. Just have a look at your WhatsApp.
I'll send it to your WhatsApp. Is that okay?
Yes. Or to my email. I've sent you the email. Have a look at it.
Okay, I'm also sharing this on your email. Yeah, share on your email ID as well.
Sure.
You got the email?
Not yet. I'm just waiting. Just a minute.
Hello? You got the email, ma'am?
Not yet. Not yet. Just a minute.
It's gone from here. Yeah, it's done.
Yes.
Got it? Yeah. So Vaibhav is joining in 2 minutes.
Yeah, sure, sure.
Hello.
Yeah, yeah.
Can you hear me?
Yeah, Vaibhav, we can hear you.
Yeah, but I'm not able to see anybody. What's
So,
yeah? Yeah,
you can see now?
yeah, I can see, but are you able to see me? I mean, is this the what do you call faculty thing?
Yeah. So once we are done, you can just see if you can share your screen now, because yeah, Shiny has to disable first. Stop.
I have to come start my video first,
Yeah, I
right?
can. Yeah, I can see now. I can see you. I can see you now.
Okay.
Yeah, I can see you. No problem.
So will I be the host or what exactly?
No. So the host is Shiny Surendran from Bangalore.
Yeah, I
You
know
know her
Shiny.
very well.
Yeah, from Chennai.
Yeah, so she is the host right now.
Hmm.
I'll be the coordinator.
Hmm.
And once we are done with your introduction, then you can start presenting. I'll tell you.
Okay. Okay. Let me know.
Okay.
Yeah.
So, Shiny ma'am, can we start now? Hello. Hello. Shiny, can you hear me?
No, I don't think so. She's here.
No,
Nilesh?
no,
Yes.
she's there. She's the one who is sharing the screen actually.
Is it okay? Hi, Jenny.
Hi, Vaibhav.
How are you doing?
I'm good.
I'm
How
not
are
able
you?
to. Why can't I see both of you all?
Okay. Right.
We have kept our, video off as
You
it
are
is.
the person on spotlight, okay?
That's okay.
Okay, so Shiny, I think we should start. It's
Okay.
already 4 minutes to 3, so you can just put on the presentation. So you can just.
I mean, on this thing, only we 4 or 5 of us are there, and rest of the people.
No, there are 40 participants.
Nee, but
Already there.
right now, already 40 participants are there.
Yeah, they're already there.
Okay. Okay.
Shiny, you can make the full screen, please, for the presentation.
You were able, he has to enable this. How do I understand?
I can see the screen.
Vaibhav, you can scare. You're the host now. You can share the screen.
Should I share the screen now?
Yes, please.
But you want to do it first, no? I mean, Nilesh wants to do it first.
Yeah.
Who wants to do first? Nilesh has to.
Shiny,
I
can you
start
share that presentation, please? Hello.
Okay. Nilesh, are you able
Yeah.
to see? I've made Vaibhav the host. Okay. I'm not able to share your slides.
Okay. Because even I can't share. I think then Vaibhav is a host. He has to disable.
Yeah. Vaibhav, can you disable and then come back?
Okay, sure. What do I do now? I make you or make Nilesh the host, is it?
Me
Yeah,
the host.
yeah, that's also fine.
Who that is the Shiny? You're ASNS official, right?
Yes, yes, yes.
So okay, so you can make me co-host, sort of,
Yeah.
Yeah.
I've given you the host now, Shiny.
Yeah. Yeah. Thank you. Just.
We'll start from the first. Yeah.
Can you see?
Yes.
Go
Just
ahead.
waiting. Yeah. 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 You may have to click the next when I finish. Right. So we start with the session now. So hello all. This is Dr. Nilesh Makwana, Joint Secretary from ASNFS. I welcome you all for the last webinar for the sports physiotherapy sessions. So next, please. Next, please. Yeah, so the vision for the ASNFS is to provide the access to Indian sports person, fitness enthusiasts, and the coaches, trainers on science-based knowledge in various sports science field and enable them to achieve the maintain health, compete, and win national and international events with a sporting spirit. Next, please, ma'am. So the mission statement to provide a platform for sports and exercise nutritionists and expert from allied sciences to exchange scientific information on sports nutrition and fitness sciences, and to provide scientific support to the sports person and exercise enthusiast in order to facilitate achievement of their potential. So these are the membership the people can take to ASNFS, like sports physiotherapists, sports nutritionists, sports psychologists, sports medicine specialists, physical education teacher or coaches. And for more details on the benefits and who can be the eligibility criteria, it is available on asnfs.org. So these are the benefits that you can also look at our website. Next, ma'am. So these are the series that we had done so far. First was 26th and 28th. Now today on May 30th, we are going to see the latest advances on ACL rehab. And the presenter is going to be Dr. Vaibhav Daga, who is a HOD Sports Medicine Department. So Dr. Vaibhav is a sports physiotherapist for more than 18 years of experience in the field nationally and internationally. After completing his graduation in physiotherapy from University of Pune, he finished his post-graduation from University of Bath, United Kingdom, and later he completed Master in Sports Physiotherapy in India. Simultaneously, he also done many continuous professional education courses. He has been the part of Indian and international cricket setup as a team physiotherapist with the various Indian national teams like India, India A, India under 19. He was a team physiotherapist for Pune Warriors and Delhi Daredevils from IPL. He has held many high-level positions in Indian sports arenas like former head physiotherapist Specialized Academy BCCI, former physiotherapist National Cricket Academy Bangalore, former team physiotherapist Pune Warriors, and former team physiotherapists like Mumbai Cricket Association, Uttar Pradesh Cricket Association, and Maharashtra Cricket Association. Awards that he has won so far is Best Physiotherapist in ATP Conclave 2015 and Young Achievers Award Indian Association of Physiotherapists Annual Conference in 2015. That is a brief introduction to my friend Dr. Vaibhav, and now I hand over to him for the session. Dr. Vaibhav, you can take over now.
Thank you very much, Nilesh, for the kind introduction. Hello, everybody. Good afternoon, good evening. I should say good afternoon. Sorry, I thought it's evening. Anyways,
yeah, Vaibhav, you can share your screen as well now.
I will not.
Yeah.
Am I the host again, or the co-host? I don't know what it is.
Yeah.
No, I think
I can share this. I'm able to share the screen.
Yeah, you will share the screen.
You're able to share, right?
Yes,
I can.
You can share the screen. Yeah.
Just a second. Just like my slideshow there. Wait. Something has gone wrong. Yeah.
Yes.
Yes. Everybody can see my screen now? Is it?
Yes, we can see. Yeah, it's visible.
Okay.
So, hello everyone. Good afternoon. So I'm here to speak about latest advances in ACL, its rehab, and return to sport. So, I'm sure most of you all know about what the anterior cruciate ligament is, but we're going to just go through a brief of the same. So as you can see, the ACL is considered the primary passive restraint to anterior translation of the tibia of the femur, and it provides rotational stability to the knee in both frontal and transverse planes. ACL tears are the account of around 64% of the athletic knee injuries in cutting and pivoting sports. ACLR is the commonest surgical procedure, and around 100,000 to 300,000 reconstructions are performed annually. Are they able to see me or my screen only? Sorry.
Yeah, we can see both. We can see you also, we can see your screen.
I'm not able to see myself.
Yeah.
Yeah, now I'm okay. Okay, fine. All right, fine. So that's the brief introduction about the anterior cruciate ligament, which is a very commonly injured ligament in cutting and pivoting sports, as I said, in athletic sports, in athletic knee injuries. So you've seen the number of reconstructions performed. That's a world figure. In India also, there are quite a bit of them. Anatomy-wise, the ACL is comprised of two bundles, which are named for their relative insertion sites on the tibia, that is anteromedial and the posterolateral bundle. The anteromedial bundle mostly is isometric. It's mostly isometric, slightly more tension in flexion than extension of the knee. The posterolateral bundle is lax in flexion. It is taut in extension. 15 to 0 degrees that's when it is most taut. So basically the anteromedial bundle provides the rotational and translational stability, as well as the posterolateral bundle provides more of rotational stability. So as we go ahead, there's a small video of the ligament. If you can see that, that's the ACL ligament. And that's the anteromedial bundle, which is blue in color, and the posterolateral bundle. So anteromedial, as we said, is providing the translation and rotational stability, and the posterolateral, mainly the rotational stability. So that's how the makeup of the ACL is. Let's talk about the mechanism of injury. There are three ways in which the ACL is injured. It's usually called contact, non-contact, or indirect contact. So direct contact injuries are very well seen, as you can see this video here. I'm going to play that again. You directly can see that there is a contact onto the knee, and which causes the ACL to get injured. Usually direct contact injuries in the overall injuries is 30% and they're definitely not an isolated injury. So there will be a comorbid structure which will be involved, like the meniscus or the cartilage or any other ligaments. So if you can see in this picture also, it's a direct contact with the knee from the shoulder of the player here, as well as here there there was again a sort of an indirect contact in this picture. So as you see, the non-contact injuries, 70% are non-contact injuries, typically valgus stress, landing, cutting, and they occur within 30 to 50 meters per second from initial contact of the foot on the ground. So I'm just going to play this video.
That is not a particularly happy sight.
If you can see, this is the football player Michael Owen, how he, if you can see his left knee, that's where he injured it. He went into a valgus stress while the foot was planted on the ground, and it was a non-contact injury. And usually they say these kind of injuries can happen if there are any kind of other issues into the lower limb before. Surprisingly, during this time, as per the information, he had a foot issue. He had a foot injury before, and he had not completely recovered, possibly not completely recovered. And possibly that was the reason he injured his ACL in a non-contact way. Going further, valgus motion while landing with the foot in contact with the ground, as I said before. There's another video which shows that's how he tried to change the direction suddenly, and that's where he lost, and the valgus stress injured the ACL. It is mostly due to the ill-timed neuromuscular firing of the structures around the knee. That's how a non-contact ACL occurs. There's another mechanism of an injury in the non-contact way, which is a hyperextension. In the hyperextended knee, it is basically injury with the foot in contact with the ground. If you can see that cricket player there trying to stop the ball, he extended his knee into hyperextension and landed with an ACL injury. Similarly, this is the picture of the great footballer Ibrahimovic. That's how he injured in the Premier League when his foot was in contact with the ground and there was an hyperextension force which injured the ACL again. So these are the ways. And the third type, as I said, the indirect contact. Indirect contact is when a person or object strikes a part of the body other than the knee itself, causing excessive forces to be transferred through the knee. There was a video here. There it is. Anyways, we won't go into that. Can you still see my screen, guys?
Yeah, we can.
Yes, yes.
Is this good enough, or should I go to the slideshow again? I mean, I'm just wondering.
It's better to go to the slideshow than it's.
Okay. Okay.
Yeah.
Just a minute, guys. Excuse me for this. I just a little bit naive about these webinars. Usually some kind of a technical issue happens. Anyways, sorry. So as I said, when a person or object strikes a part of the body other than the knee itself, causing excessive force to be transferred through the knee. So I just wanted to come across, give you a few facts, how the ACLs are injured. The non-contact ACLs, as you see, compromise of 70 to 85%. It's as described by the Walden et al. In 2015. There's a peak incidence in females about 14 to 18 years of age. Peak incidence in the males is between 19 to 25 years of age. Sanders et al. In 2016 said that. Contact injuries, 15 to 30% of all the ACL injuries. Females are more vulnerable at 2 to 8 times greater risk of tearing the ACL. If you can see, odds of rupturing an ACL is 1 in 1,750. But at the same time, re-injuring an ACLR or rupturing the other ACL is 1 into 33. So that's why our role as physios or as the rehab specialists or as the rehab team, we should be very much involved into the safe return of the players to the sport, because ACLR has got a high incidence of re-injury and rupturing if the rehab has not been proper. We just covered the incidents. We're just going to go a little bit more into the depth. As I said, over 2 million ACL tears a year. I spoke in the first slide about 100,000 to 300,000 ACLRs done. So 2 million ACLs a year, about 80 per 100,000 citizens. We're talking about general, it's not only about sports. It's overall. Greatest prevalence is in young females, as we saw in the last slide, 14 to 18 years of age. 3% of amateur athletes injure their ACLs, but as high as 15% is the elite athletes, though. So it's more common in professional sports, in elite sports, because that's the demand of the sport. That's the way the player or the sports person appear, and they carry out their functions on the field, so with 100% dedication. And so definitely their training levels are high, their body makeup is high, their biomechanics are different as compared to the amateur athletes. And that's why the rate in them is much more than the amateur athletes. Non-contact injuries, 3 to 5 times more common in females. That's a debatable, that's still being researched, but people, according to the research, it's because of the anatomy of the female notch. Sometimes they say that's why they are more vulnerable to the non-contact ACL. This rate decreases as female athletes mature, but still disproportional at a professional level. As you see, at the professional level, it's more females who get injured. So looking into, I'm not going to go into the assessment and everything about the ACL. That was just a brief introduction and a few facts and the incidence of injuries. But what treatment options do we have as we go ahead? There is a non-operative way, going conservative way, which of late I've come across one evidence about the healing of the ACL, which was done after 25 weeks. MRI done after 25 weeks showed there was a good healing on the MRI. So though it's poorly tolerated, still work needs to be done a lot in the non-operative method of treatment. Of course, repair were initially the ACL repairs had started. They were not very famous. It was not very well taken up by people. But these days it's coming back into the picture. We'll see further how it is. Of course, reconstructions, these are the main things, what we are here for, what you're here to listen to me and understand how do we go about them. So reconstruction ACLRs are 2 types, basically allograft and autograft. So I'm sure autograft is basically a graft taken from the patient's body itself, like a hamstring tendon or a bone patellar tendon bone, BPTB as we call it, or the quadriceps tendon, which is the new latest one, kind of a graft which is coming into the picture right now, into the scene right now. So I'm sure everybody understands about the allograft and the autograft. Now, allograft is basically a cadaveric graft which could be taken from a cadaver from any of these 3 tendons again. What are the types of reconstruction? The types of reconstruction are basically non-anatomic versus anatomic. We have to see what are the things, why the non-anatomic was initially when the reconstruction started. They were doing a non-anatomic positional. The footprint of the ACL was not fixed at that same point where the ACL was ruptured from. So non-anatomic, it was said to be very vertical. It gave a good anterior-posterior stability, but the rotational stability compromised, and the graft failure because of the tunnel placement was very common in a non-anatomic reconstruction. Anybody has a question or something? I don't know. Sorry, okay. Anatomic, restoring native ACL footprint to recreate the native functional kinematics was important. And that's the one which all the surgeons to these days prefer, to do the native ACL functional kinematics, to be restore them and restore the ACL footprint so that it exactly works as the injured ACL, back as the injured ACL. Although it's not one size fits all. It has different types. You have to have a different types of graft. It is basically a double bundle and a single bundle graft. Double bundle graft is to reconstruct both the anteromedial as well as the posterolateral bundles. Very much required. Why do we need to know this? Because the biomechanics change accordingly, and it can affect further ahead for our rehabs. A number of studies demonstrate that the biomechanical promise of double bundle reconstruction fails to translate into clinical significance and may predispose the graft to impingement and excessive tension through the posterolateral bundle during the knee extension, resulting in early graft rupture or attenuation. So initially they started with double bundle surgeries, but again, as I said, the double bundle, usually what is a double bundle and single bundle? I'm just going to give you a brief about it. Double bundle is considered depending upon the size of the notch where the ACL is going to be fixed, the femoral as well as the tibial. If it's a larger notch, then it's more than 14 millimeters usually, that's what the surgeons say, or the literature says. Then they use a double bundle. A single bundle is used where the notch is not more than 12 millimeters. So that's how they decide about a single bundle and a double bundle surgery. Biomechanical studies demonstrate that anatomic single bundle grafts tensioned either maximally into extension or submaximally at 20 to 30 degrees of flexion most closely reproduce the native knee kinematics. So these days, it's come back to single bundle surgeries, and single bundle surgeries doing it at the native ACL footprint. I mean, reconstructing it there, possibly using the remainder of the ACL stump, and with it they do it. It gives more natural healing or more natural way of the ACL where it was ruptured from. So as such, double bundle reconstruction has lost momentum in favor of the anatomic single bundle reconstruction. So that's how it has come across. What are the different types of graft? As we spoke about it, we just mentioned about it before, it's bone, patellar tendon, bone, hamstring tendon, or quadriceps tendon is the latest one which they are looking to use. I've not seen many of the quadriceps tendon. Most commonly, what we do at Kokla Vinabani Hospital, Dr. Pardiwala or Dr. Gajjar, who do them, is mostly the hamstring tendon. It's supposed to be a very good graft, and rehab-wise also, it's very good. Although there are some pros and cons in both BPTB as well as the hamstring tendon, but that's what is commonly followed usually at our practice here. Autograft is considered in young active patients. Definitely, it is much better for the young active patients to go through the autograft rather than allograft, because allograft has seen a lot of failure in that middle-age people. Sorry, the young age people, not the middle age, and a non-irradiated allograft has been the choice in older and non-active patients. In middle-age recreational activity patients, acceptable and equivalent to autograft was, I mean, the same allograft was used in a middle-aged recreational activity patient. But the strict rehabilitation parameters were followed for around 8 to 12 months for the ligamentization to happen before they get back to their recreational activity. Definitely not in a middle-aged professional sportsman. We won't be using the allograft, but they have tried using it in the middle-aged recreational activity patients, which has given them a little bit of success. But of course, their rehab is going to be delayed till around 12 months. Yes. So as I was talking about the quadriceps autograft, according to a study in 2017, the graft, they say it's the graft of the future. There was a follow-up study done in 2018 also. The BPTB and the hamstring autografts have been the long considered main graft choices for active young patients, as we saw in the earlier slide. The BPTB gives donor site morbidity and anterior knee pain. That's the disadvantage of the BPTB. As I said, there is a couple of disadvantages of these grafts also. Hamstring graft gives an equivalent function, less donor site morbidity, but at increased laxity, and the graft failure rate is higher in the hamstring tendon graft. If you look in the long run, it was done in a 2-year follow-up study, and that's what they found out. Quadriceps tendon was basically used as a revision surgery, but it's now a choice of as it has less donor morbidity. It gives you the strength required. As per Fisher et al., who did the study, quadriceps is an antagonist to ACL. We call quadriceps muscle as the antagonist to the ACL. Slightly impaired function of the muscle may protect the ACL graft. So this gives a better result. They demonstrate significantly higher hamstring to quadriceps ratio than the hamstring tendon grafts within 1 year after the surgery. That's what also found out. So a recent systematic review does conclude that QT, the quadriceps tendon for ACLR is safe, reproducible, and versatile. So possibly not many, but yes, surgeons are looking into doing the quadriceps tendon because it's an evolving procedure, the ACLR, and the various grafts have been done. Right now, as you said, the laxity in the BPTB is lesser, but it gives anterior knee pain and gives the donor site, but the morbidity from the donor from where the graft is harvested is an issue. Similar to the hamstring tendon, it's a less donor site morbidity, but the laxity and the failure rate is higher. So you have to decide which to do according. And of course, it is very much dependent on the patient's age, activity, and his natural makeup of the site. Yeah, as I said, yes, the primary repairs has also come into the picture these days. Historically, poor outcomes have been associated with the primary ACL repair. Recently, there has been increasing interest in ACL preservation as an option to perhaps better restore the native ACL anatomy, biomechanics, and the neurosensory function. Because if the stump of the ACL is retained and tied up with the new ligament, they say they have found better neurosensory functions and biomechanics, giving the rehab times, a quicker and accelerated rehab protocol could be followed. Primary repair aims to preserve the native ACL's inherent healing capacity, so proprioceptive function and the knee kinematics. Primary ACL repair may be considered in the setting of a proximal tear. Basically, in proximal tears, they definitely consider a primary ACL repair with a good tissue quality. So as I said, it depends upon the tissue quality of the patient, the activity of the patient, and everything. So whereas ACLR remains the preferred technique in non-proximal tears and those with those having concomitant ligamentous injuries and those with poor tissue quality. So limiting early ACL focus rehabilitation. As I said, the rehabilitation time would be affected depending on what is the surgical option the surgeon has taken for the repair or the reconstruction. I just want you to know a few terms. It's about there is this new procedure. What the surgeons have started doing is they said at the middle junction, the ACL is the most weakest, and it can tear from the middle at the middle junction, middle third. So they have started internal bracing. So basically they do a bracing, they do it with some artificial material, which is bioabsorbable, or the ligament. They cover the ligament with an internal sort of a brace, so that it gives extra protection to the new ligament, and possibly make changes in the rehab plan. Then there is anterolateral ligament repair also, which is done. They found out this ligament about the anterolateral repair. They've been doing a lot of, as you can see, there's an anterolateral graft which is giving extra stability to the knee, which will help. Then, of course, about the biological agents like the PRP and stem cell, though there is limited evidence, and that's not much supportive evidence of that it can work. The PRP in a ACL tear or a stem cell regeneration, it has to be still studied further to see how beneficial they can be and replace the reconstruction. As we see, the contributing factors to the ACLR is possibly relative stronger quadriceps to hamstring development, aiding to anterior translation forces. 60% children with hemarthrosis. If you see children with hemarthrosis, you should suspect and ACL tear. 15 to 44 years, main age group, less than 19 years, they are at a larger risk. Initially it was, this is an old study which said about male more susceptible because of the sports they involve into. The numbers are higher. Knot size, narrow femoral intercondylar notch gives a higher risk to the ACL. How about the prognosis? The prognosis is basically depends on the patient's requirements for future knee function and whether they decide to have a surgical repair or not. Patient must decide whether they are prepared to reduce their activity level if the rehab is completely not done and they not able to return to sport. Post ACL reconstruction, graft at a maximum strength at the time of surgery. 6 to 12 months, 6 to 12 weeks, graft strength is at its weakest. So you have to be very the plan has to be adequate, that the rehab plan is such that into 6 to 12 weeks you should not strain the graft more for the failure to occur. So in 9 months, graft begins to regain its initial strength due to synovial growth and revascularization. So that's why we talk about return to sport is around 9 to 12 months. Anything after 9 months, they say, or 6 to 9 months, sorry, not 9 to 12 months, but 6 to 9 months is what the latest studies have shown. Management decisions in the rehab, if it is to go, if the ACL, there is a primary ACL tear and the patient is coming to you, to go conservative or to go undergo surgical reconstruction is a commonly faced scenario. It depends on the limitations of the ADLs and the participation in the low risk sport. Avoidance of twisting and pivoting activities increase the likelihood of recurrent injuries. Assessment of conservative management approach. One study by Colton Mackler, they did no more than 1 episode of buckling since the onset of injury. Score at least 80% on the timed hop test. Score at least 80% on the knee outcome survey and the ADL scale, and score 60% on the global rating scale. So these are the scales this was the way they assessed to decide whether to go conservative or go with the reconstruction or the repair way, basically the reconstruction way. Other conservative management should only occur when there is no other concomitant ligamentous injury more than grade 1, no repairable meniscal injury, or no full thickness cartilage tear. So if these concomitant injuries are not there, then we can definitely, and if it's isolated ACL tear only, possibly, and if depending again on the test, what we discussed in the earlier slide, if they give a positive result, possibly you can think about going conservative. In the elite athlete, ACL repair is absolutely required, and even a trial period of conservative rehabilitation is probably just delaying the complete recovery process. So if it's an athlete, we know the high demands of sports on his knee, there is a lot of pivoting and lateral movement in the sport. So definitely it is recommended to undergo ACLR. Without surgical repair, the risk of secondary meniscal or articular cartilage injuries is high. 70% of untreated patients develop radiographic evidence of arthrosis after 10 years. Okay, once you diagnose the ACL, and what are the options? What are the options of going about the repair, about the management? So the acute management, it's the new acronym which has come into the picture. It's called Peace and Love. So we call protection first. So protect the ligament. So if the player has come to you and there is an acute injury of the ACL, definitely protect the limb. Don't load the limb so much. Rest it as much as possible, because there is definitely going to be some bone bruising. There can be probably some cartilage involvement or the chondral wear and tear due to the injury. There will be definitely swelling. So elevation is required. Avoid anti-inflammatories. Anti-inflammatories are the ones which are not going to, actually they have been said to hamper the healing. They have been said to hamper the healing. So we should avoid the anti-inflammatories in this initial acute management. Compression has its own place to reduce the edema. So possibly that definitely should be done. Education about the injury, and make the patient understand what exactly the injury is and what are the pros and cons, what going ahead, will they need a repair possibly, or will they need a reconstruction accordingly, or they need to go conservatively, depending on, so you have to make those clinical decisions and educate the patient at the same time. Load, so load has to be managed, possibly there has to be a optimal load. It definitely cannot be more load. They say the optimal load also promotes healing, and to come back from the injury at the earliest. So definitely optimal load is the way ahead. There has to be optimism. It has to be, you have to be optimistic about the injury. So that has to be mentally. So it's kind of this acute management is more of a biopsychosocial model. Vascularization has to increase, and a light exercises to maintain the muscle strength and the muscle toning, so that the return after the acute management is easier, or the further management of ACL injury is much better. We're going to put it, before we get on to the rehab, there's a word on the pre-op rehab, which we need to understand. So we call it as prehab also. So the rehabilitation should begin before the surgery whenever possible. So usually you say it requires around 3 to 5 weeks. Usually 3 weeks, 21 days is a good enough prehab. What you can do, you aim to reduce the swelling, inflammation, and pain, restore normal range of motion, normalize the gait, and prevent muscle atrophy prior to the surgery. So to start, for the surgery to be successful, a good prehab, there are lots of studies which have proven that a good prehab will help the post-operative rehab. The post-operative rehab progression is also easier, and it's smooth. So prehab holds a very big importance in an ACLR surgery. So full motion is restored before the surgery due to the risk of post-operative arthroplasty. So we have to ensure that the full motion is restored before the surgery is done. That's why these days the surgeons usually, they don't operate the ACL in the very first week of its injury, or the first 2 weeks of injury, possibly 3 weeks. They usually give 3 to 4 weeks. That's what we follow at our institute at the Kokilaben Ambani Hospital. And the patients undergo a prehab and then we make sure that it comes back. As I said, the patient education, a critical aspect of pre-operative rehabilitation. You have to make the patient understand what exactly is expected, what are the timelines expected, when he can start running, when he can start loading, how it has to be. Of course, it will depend upon the concomitant injuries also. If there is a meniscal injury, definitely the loading is meniscal, or a chondral injury, the loading is going to be delayed. If there is a lot of bony bruise, the bony bruise has to settle down before the surgery is even attempted. Of course, because of the surgery, there is going to be issues around, because of the bone has to be bruised because of the drilling and the tunnel making and placement of the graft. So all this has to be explained to the patient in the preoperative stage, so that they are well aware of what is expected ahead from the postoperative rehabilitation. As I said, the studies have shown it helps postoperative progression more easily, especially in the earlier phases where the ROM is important to be achieved. So it helps the ROM definitely. So going ahead, we're going to talk about the principles of ACL rehabilitation. That's what mainly our focus is. I mean, we as physiotherapists or rehabilitation team, I'm sure there in the crowd, there are a few sports science people also. So this is the main thing. So principles of ACL rehabilitation is you need to have initially full passive knee extension has to be started according to the study, which according to the evidence which came out in 2012 regarding the ACL rehabilitation. And this rehab was considered to be about a graft which was bone patellar tendon bone, BPTB graft. So patellar tendon graft was basically considered to decide the rehabilitation phases. So these are the restored patellar mobility, reduced postoperative inflammation, range of motion restoration, re-establish voluntary control of the quadriceps, restore neuromuscular control, gradually increase applied loads to strengthen the muscles further, and lastly, progress to the sport-specific training, and finally, the return to sport. So, as you see, full passive knee extension is achieved by various ways. You know, passive sometimes it is even active these days. So with a towel roll below the heel and doing the pushing of the knee down so that the extension is achieved, because this is what is required. So similarly, if you see in the picture up here, they have tied the thigh, they fixed the thigh, and the heel is kept onto an elevated surface. And again, the patient is asked to do the knee extension. So kind of passive active knee extension, low prolonged stretching of the calf muscle also is required, and prone terminal knee extension. This is the new exercise which I use a lot in my practice. It's to achieve the terminal extension, which is required during which is very important to be achieved, because if there is no knee extension, then the knee there will be an issue with the gait, and if the gait is not proper because of the not full range of extension, then it will affect our loading, and if the loading is affected, and the further rehabilitation steps will be again affected. So it is important to achieve that full knee extension in the first 2 weeks. Restore the patellar mobility. The loss of patellar mobility is referred to as an infrapatellar contracture syndrome, results in the range of motion complication and difficulty in activating the quadriceps. So if there is a contracture or at the infrapatellar site, and the patella is not moving into its groove properly as we would like it to, the activation of quadriceps will be difficult, and that will again cause the extension lag and not give you the terminal extension, which will again affect our rehabilitation further. So mobilizations are performed in the medial and lateral and superior inferior directions of the patella. Basically, the inferior guided patellofemoral joint mobilization are utilized to encourage the gains in flexion. So they have been shown to give the gains in the knee flexion range of motion, which also has to be achieved as we see further in the range of motion slide. We will see it in the further. Reduce post-operative inflammation. Very important, the post-operative inflammation has to be controlled, or something like a game ready, a compression sleeve or a cryo cuff or a normal icing with some compression bandage will be useful to reduce the post-operative inflammation. Spencer et al. Hello. Hello.
You can proceed, Vaibhav. I think the participants
Somebody
must have unmuted.
unmuted.
Yeah.
So
Kindly,
we can mute them, right?
Sorry about that. You go ahead.
Yeah. Can we just mute everybody? I mean, yeah, all right. As identified by the Spencer et al., mechanoreceptors in the joint capsule respond to changes in tension and in turn inhibit motor nerves supplying the quadriceps muscle. So that's why if there is this inflammation in the joint, the quadriceps muscle activation will be affected, and that will give us an issue to have a good quadriceps contraction to go ahead for the rehabilitation. It is said, even, I mean, other study which I came across some time ago was even a half teaspoon of effusion in the knee reduces the size of the quadriceps by around half an inch. That's what it was said. So it's very important that the inflammation is controlled so that a proper quadriceps activation will be possible. Therapeutic intervention utilized include as I said, the common commercial cold and compression device like the game ready here in this picture, or the cryo cuff, or anything to do which can compress the knee and give a cold compression. The range of motion, flexion goals of 120 degrees should be met by 4 weeks following surgery, and full symmetrical flexion should be achieved by 12 weeks. Various ways to do the flexion range of motion exercise. As you can see by the bedside, you can use it, helping the other limb to flex the knee. Then a bicycle ergometer can be used, where the seat can be adjusted accordingly to how much of flexion you require and how much can be possible, and so on and so forth progress. So employed through further progression gains in flexion range of motion include wall slides. Wall slides as a very good exercise to achieve the range of motion. We've also used the Swiss ball to gain the range of motion at our practice at the Coquelin. Active assisted range of motion sitting or on a step, and one half moon movement on a stationary bicycle will help the range of motion back. Quadriceps stretching of the side of a plinth, and usually in a prone position, is introduced to the patient's program. So either, if you can see in the picture, they are trying to stretch the quadricep with an assisted band. That's the way, one way we can achieve the quadriceps this thing, or in a prone position. Similarly, you can pull the quadriceps for the knee flexion, in the knee flexion, so that the quadriceps can be stretched again. Soft tissue mobilization or massage can be of particular benefit throughout the progression to restore the full symmetrical flexion and the range of motion. So that's how we will achieve the range of motion exercise, range of motion, the flexion as well as the extension. And that's how we will go ahead. Re-establishing the quadriceps control. A lot of studies have shown neuromuscular electrical stimulation has helped to gain the quadriceps control back. So basically, the quadricep control is done with an active quadricep contraction with the stimulation from the neuromuscular electrical stimulation, and it will help for the musculature to grow. So electrical muscle stimulation, as I said, biofeedback are often incorporated into therapeutic exercises to facilitate the active contraction of the quadricep musculature, as described by Kim et al. Neuromuscular electrical stimulation combined with exercises, as I said, was more efficient than exercise alone to improve quadricep strength after ACL surgery. So the quadricep control and the strength is achieved very well by the neuromuscular electrical stimulation. It has got a quite a good strong, medium to strong level evidence that this electrical muscle stimulation for the muscles of the quadriceps help to regain its strength and help its further function in the rehabilitation. Neuromuscular training. It was first introduced in 2001. ACL contains, as we saw before, mechanoreceptors and directly influences the neuromuscular control of the knee. ACL deficient results in a loss of proprioception, as we all know that because of the mechanoreceptors present there, the ACL deficient knees have loss of proprioception, postural control, and recruitment patterns. So vital part of prevention, so neuromuscular training is also vital part of prevention and prehab, and through the post-operative phase needs to be maintained indefinitely to prevent re-rupture or tear to the contralateral knee. So neuromuscular training is holding a very important place in the rehabilitation from an ACL reconstruction procedure. Start as soon as walking full bed bearing is allowed with gentle, non-complex exercises using minimal weight and developing from static to dynamic. So what is static to dynamic? I mean, you start with simple standing up on your feet, weight shifts, starting with that, progressing it to the stability trainer, progressing it to a more unstable surface, or if you can see, as you can see in the picture, you can use of the Biodex neuromuscular training instrument. With this sort of an instrument, there is an instrument which usually gives you stability training, and that will help the neuromuscular training. Of course, these are the ones. So as I said, non-complex exercises using minimal weight and developing from static to dynamic balance training and plyometric exercises into agility training and sports-specific exercises. So that's the progression we do for a neuromuscular training when we talk about the neuromuscular training control to gain back. This is just an example how usually a proprioception training in soccer is done with the Bosu balls, with the different runs and including the ball into it. So they do a lot of things for the lower body, as you can see here, jumping onto the trampolines, using challenges like doing different drills. So they can be, this can be used as prevention exercise, as it has been said, it is used in prevention of the ACL. Also in the prehab, it can be used, of course, in prehab because the ligament is injured. Possibly they may not be doing the same with the same intensity, but it can be started with lower static, going to dynamic, and then using sport-specific drills to achieve the neuromuscular control. So these are the various ways, as you can see, how the athletes are, how the football players usually do. They use it a lot in as a prevention mode into the in soccer and in football. So because that's the most vulnerable sport to see a non-contact or a contact ACL injury. Gradually increasing the applied loads. We talk about we got to talk about the closed kinetic chain. We know that closed kinetic chain exercises are included in very early into the ACL rehab. Many of us have come across with that. So including the leg press and squats inside a pain-free arc of motion are introduced, as these activities have been shown to minimize the stress on the ACL. So, so it is achieved so that the muscular control and muscular growth of the disused muscles is back, and it is minimized the stress onto the ACL. Limited evidence now demonstrates that open kinetic chain exercises inside 90 to 0 degrees arc of motion may not compromise graft laxity. We're going to see further how it is developed that we can use the open chain kinematic exercises also, not very late, but into at the same time as the closed chain kinematic exercises. So the range of motion open chain kinematic exercise progression begins with the multi-angle quadricep isometrics inside the 90 to 40 degrees of arc of motion. So it's kind of an inner range in which if we do and we don't reach the end of the range, there won't be any kind of there won't be any effect onto the graft. So it is very safe to use the inner range of quadricep strengthening in the as an open chain kinematic exercise. Strong evidence that both closed chain and open chain exercises can be used to regain quad strength. That's the conclusion. We're just going to talk about it more. I'm thankful to one of my colleagues to come out with this study, and which we took it together. Open kinematic chain exercises have been strictly avoided traditionally. If you talk about the first ACLR, open chain kinematic exercises were not allowed at all. The terminal knee extension definitely was not allowed in an open chain kinematic way. Isokinetics, especially when the Cybex, it was the only thing which was allowed initially when the ACLRs started. That was the only exercise permissible. Got rid of our knee extension machines usually when we never used the knee extension machines in a ACLR rehab. But as you see, we talk about the closed chain kinematic exercises, reduced anterior tibial displacement, which occurs with an isolated open kinetic chain exercises, quadriceps contraction. The primary aim of the review was done seeing the effect of open versus the closed chain kinematic exercises, was to determine whether open kinematic chain exercise, quadricep exercises result in differences in anterior laxity when compared to the closed chain kinematic exercises at any time point following the ACLR. Secondary aim was to determine whether there are any differences in the strength, function, quality of life, and adverse events with open chain kinematic exercises in the same study when compared to the closed chain exercise at any time of the point. So as you see, would it make a difference, early versus late introduction? In an early introduction, slight increase in laxity, especially in the hamstring group or in the hamstring tendon, no difference in strength, no difference in patient-reported functional outcomes. In the late, no real difference in laxity, no difference in strength at the short-term or late-term follow-up, and no difference were found in the patient's reported functional outcomes. So it really depends how do you want to take it. So in conclusion, as I said, early introduction of open kinematic chain has a limited to moderate effect on anterior tibial laxity, but it is also had limited to moderate effect on the strength. So patient reported function and the physical function. Adverse effects are poorly reported in these studies. So this hasn't really answered the question of the safety of early implementation of open kinematic chain exercises. The hamstring graft may potentially be more vulnerable to laxity than the patellar graft, but this conclusion is based on, again, limited evidence. So we cannot really come to a final conclusion of whether the open chain kinematic exercise to be introduced early or late. But as I said, in the inner range, it will definitely be safe. Not enough studies on women who we know have found to have increased laxity when hamstrings are used. So maybe more vulnerable to increased laxity with the early open kinematic chain exercises. So particularly dealing with the female athletes or the female ACLR patients, you should consider these factors of starting the open chain kinematic exercises early or not. But I would say here in that range where we talked about in between 45 to 90 degrees or 30 to 60 degrees, or basically 30 to 90 degrees, which is the inner range, would be good and safe to start the open chain kinematic exercises in an ACLR rehab. We progress to the sport specific training. After 2-3 months post-op, depends upon person to person, depends on case to case. If ROM is within normal limits, and sufficient strength is demonstrated via pain-free 8-inch step down without deviation. So this is a step down deviation from the 8-inch step, what we do to see if there is any deviation in a valgus strain happening, or there's a deviation inside. So a running program is started accordingly if everything is positive and there is the range of motion is back, there's sufficient strength, and the 8-inch step down has not any deviation on the knee. So we definitely can start the running program at that time when we are talking about progressing to sport specific training. A running program is progressed with an emphasis on speed over shorter distances versus slower long distance running. So that's how running is preferred in a sport specific training setup to come back to these sports. Plyometric training is then incorporated only in full range of motion, and adequate strength, base, and flexibility is demonstrated. So you progress to plyometric training after the running when we, of course, have a full ROM and adequate strain, base, and flexibility is available. Then only you can think of, people who are into sports science or into the advanced rehab of the ACLR. You have to understand that the full range of motion, flexibility, the strain base is very important to initiate the plyometric training. Agility and deceleratory training are important interventions to include the later phases of rehabilitation in preparation for the return to sport. So that's how a progress is achieved in sport-specific training. So usually what happens at our end in our practice here is once we achieve the full range of motion and adequate strength, we refer our cases or the ACL patients, the ACL reconstructed patients, to our strength and conditioning department. The sports scientists take care of enhancing their strength further. And once they see, and we keep, I as a physio or my team of sports physios, they keep a track of keep a track of every patient on a very probably 3 to 4 weeks basis to check how they have progressed. And if they have no complaints, it is the sports scientist who takes care and only comes back to the physio when there is when we are planning the return to sport. So that's how it is. So that's when a reference is given to the sports science team. We're going to just at this point, do you just want to, it's been almost an hour, I believe. Do you just want to take a break of 5 minutes or something, guys? Shiny?
Vaibhav, can we take questions? Are you ready? Nilesh?
No, what I'm thinking, you want to take questions in between and then take it at the end again?
Yeah. How many more slides are there?
There are, I have to see exactly. But there is a complete return to sport thing which is still left. So we can take, I thought probably the people would have been a little bit. Sorry?
Yeah.
Sorry?
Let's take some questions. Maybe Nilesh can facilitate.
Yes, please. We can because it's been going only one way. So it is nice to be interactive. I can answer it. We can go back.
Yeah, so
Vaibhav, I think it's better if we can take the questions. If somebody is asking in terms of return to play criteria, you can show the, the criteria that you set for the return to play.
Yeah, that is going to be further in my presentation.
Yeah.
Just let me, where I can see the question. Are there any questions right now?
Yeah, on the chat section, you can see the question.
Just a second.
Yeah.
How do I access the chat, Nilesh?
Oh, no problem. You guys, I'll explain. I'll tell you. You can answer basically. So I can read out the questions for you, and you can answer. Is that fine?
Yes, definitely. And who is asking it? I mean, if you can just.
Yeah. So there is one question from Ashwini. Can you explain the assessment criteria, the four criteria that you have said in your presentation?
Assessment criteria of for what? You're talking about going
So
conservative or going surgical way?
Yeah, I think it's a surgical way, I guess.
Yeah.
She has not
Specified. Can Ashwini be more specific about the question, please? Because this is an incomplete question, Ashwini.
And there is one more person who has asked question before Ashwini can, clarify the question. There's one question, that is, how do you manage a cycloplesion? Can you hear me?
Cycloplesion.
Yeah.
Yeah, I mean, it depends upon. Usually, it is usually managed conservatively if the surgeon sees a cycloplesion there. So definitely the normal. I can see these. I think more. Wait a minute. Okay, I can see the questions now, Nilesh.
Yeah, good.
Yeah. How do we manage a cyclops lesion? Yeah, cyclops lesion is basically managed. It is not managed surgically, but yes, you have to do it with a medical way as well as pain management, depending upon what the pain and what the how much is the pain, and then accordingly give rest and come back with the exercise program. So exercise program, you cannot be more when there is because of the cyclops can possibly cause some impingement also. So the weight bearing, the loading is rested for some time, and then we come back to it very depending on a gradual loading basis. Okay, then there is. So can you explain about important don't during 4 to 6 week protocol for OKC? And as I said, Dr. Shabieta, as I said, during the first 4 to 6 weeks, closed chain, definitely I'm going to be talking about it when we go about when we go to the phases of the rehabilitation. I was just mentioning here about everything else. So the protocol is, as I said, in the open chain kinematic exercises, because the evidence is not enough for us to give a full terminal range of extension. It is better to give the open chain exercises into an inner range, which I talked about, around 40 to 90 degrees or around 30 to 80 degrees, whatever, in that limited range. So you don't go to the terminal extension 0 degrees in open chain. And similarly, the closed chain exercises, as I said, all of them can be started like from we progress from the wall squats to the supported squats to the box squats and the normal squatting progression as you have. You definitely can start lunging also supported, and as per the patient's tolerability and way, we can continue doing the same thing depending upon the patient's pain perseverance and his ability to understand the movement. Abhishek asks me what the timeline for prehab. As I said, Abhishek, in the presentation itself, 21 days is a good enough prehab to be done before a surgery. But our aim is to achieve the full range of motion before the surgery. If the full range of motion is not achieved, then probably it can go up to a little bit till maybe around 5 weeks also. But the goals to be achieved in prehab should be there. Then only we can think about going ahead for the surgery. And usually the surgeons demand that the full range of motion and a good quadriceps strength. I mean, I'm not saying a complete quadriceps strength, but a good quadriceps activity or contraction, which will help them in the post-rehab phase, post-operative phase, sorry. Kavita asks, what is the significance of gaining terminal knee extension post-op? Is there any time limit to achieve it? Usually, as I said, there is a time limit of around 2 to 3 weeks where you need to achieve, because before you start weight bearing, when you start the weight bearing, the knee extension should be full range. And if the full range is not there when you start the weight bearing, the gait will be a difficulty and the gait will be not normal. So that's why it is needed to achieve before you start the weight bearing to have a complete extension, and it will have better results in the rehab. Kavita. Mihir says cyclops are usually detected. Yes, cyclops are, yeah, right, Mihir. It is detected by fresh MRI, but it is not always there in the start of the, as I said, but again, if they are detected, then you basically have to manage accordingly with medical management and offloading. Ashwini again asks, yes, sir, before getting to ACL rehab in between conservative and surgical management. Yeah. So as per that study in 2003, which they demonstrated, they wanted an 80% once because the prehab is done in those days, and if the 80% of hop test distance is achieved, or I'll go back to that slide later on. Or you want me to go back to that slide? So yeah, no more than one episode of buckling since the onset of injury. If there is more than one episode of buckling from the onset of injury, from the time the ACL has been injured, you definitely are ruling that patient out and going on for a ACLR rehab, ACLR reconstruction, ACL reconstruction. Score at least 80% on the timed hop test. The timed hop test as compared to the normal, 80% on the timed hop test, 80% on the knee outcome, the surveys what we have, the KU score as well as the ADL scale, and the 60% on the global rating. These are the various scales which you have, which you can do achieve your 80% of knee outcome score and the 60% of the global GRS scale and hop test. These are the 4 aspects to decide if you have to go conservative or go ACLR way. And this was only one study which I found out on, that was in 2003. It has to be looked further into. Of course, it's a surgeon's decision also. Sudhanshu Sekhar, open kinetic chain exercises, within which range we can start initial and AC? As I said, Sudhanshu, I answered that question earlier, Sudhanshu. As I said, in the inner range, around 40 to 90 degrees, from 90 degrees to around 40 degrees of flexion. So you don't go to complete extension, don't go to the terminal extension or the last range of extension. How do you manage the acute on-field injury? If it's an ACL and you're confirmed on field that there is an ACL, you definitely stop the player on the on field. You basically, so you have, if you're a sports physio with a team or in a sports setup and you're seeing the sport, you will understand from the mechanism of an injury, what was it an ACL? And it's a very, a pop or a crack is a sound which the player will tell you. And if you think about a pop or a crack, and when you do a little bit of the Lachman test on the field itself, it would usually give you an idea that possibly this is an ACL and he cannot continue to play. So you definitely get him out of the field, and he needs to be substituted if it's a football. If it's in cricket, you definitely cannot do anything about it. He needs to go out, and he possibly has ended his match. Then depends on the sport also. If it's a substitution which you can do, definitely you would. But usually that's the way an on-field ACL would be managed. Joshita asks, so what is the usual duration of rehab in a conservative management of ACL injury? It's the same, it's almost the same, nothing less than 6 months for sure, nothing less than 6 months, even in a conservative management, because we have to undergo the criterias. It does not change. I would treat the ACLR rehab will take a little bit more time, but the conservative management will take a little bit less time. That's the only difference between the two. But the minimum, I believe so, it will be around 6 months before the rehab ends, and nothing before the 6 months the player can get back onto the sport, or else there will be a risk of re-injury, which a lot of studies have shown. What time should we expect for return to sport? Grade 1. Abhay, depends on what grade 1, grade 2. If he is if you're talking about a conservative management, as I just answered Joshita the similar question, so it will be the same thing. But if it is a reconstruction, even for a grade 2, so usually a partial tear, it depends upon the healing. I mean, if you do a repeat MRI and you see the progression of exercise, but I believe nothing less than 6 months. Grade 1 possibly a little bit lesser, but grade 2 definitely would be around 6 months.
Yeah, Vaibhav, can you see
Yes.
the questions, right?
Yes, I can. I just went to Abhay. Next question is how the graft. What is how the graft? I mean,
that's the thing. I think she is asking. I think she has a continuing. Is there any specific protocol for different autografts surgery?
who's see?
The protocol.
Yes, there is. There is a little bit of difference in the protocol, Shabiyata. We're going to cover that as we go ahead.
Okay, so we'll take the last question, Vaibhav, because we are having a time constraints actually.
Are we? Okay.
Yeah.
I've come across studies stating that a cartilage will take more than 6 months to heal and take the stress of running. In your presentation, you advise to start running by 3 months with completion of criteria. Can you explain? Nanda Kumar, yes. If there is this is about a natural isolated ACL tear I talked about. If there is any concomitant injury for the cartilage or the meniscus, your goals and your targets will be different. Is that this what I spoke about is usually about 2 to 3 months post-op is usually a pure ACL tear, only an isolated ACL tear.
Okay, so there are last 2 questions basically. Then we end the session. Hello. Yeah. So which graft is
in grade 3 MCL also associated with ACL injuries? So which injury given first priority? Definitely the ACL, Sudhanshu. It's first, the ACL is more important, and that if it is associated with an ACL complete rupture.
Okay.
Yes, we will end the questions now and we continue the presentation.
Hello.
Yes.
Yeah, I think we may have to skip that. I think we will present it some other time because we're having a time constraint. We have some schedules also for our association. So I would suggest we can keep the other presentation or whatever, like some specific to sports or a rehab kind of criteria some other time.
You don't want to do it now?
Well, see, the thing is, it's a time constraints. The Zoom call will end at 4:30. So if you can able to finish it before that, that's okay.
Oh, is it that? I didn't know
Yeah,
about.
yeah. Yeah, so we have a time given to Zoom like 2:30 to 4:30. So 4:30 the call will the webinar will end automatically.
So then we'll take more questions, and the rest of the part when we can do it. You tell me. I mean,
Yeah, so rest of the part we can do some other time. I think most of the questions have been covered already.
are there any questions which people want to ask? Then we can spend those 10 minutes right now in that.
Yeah.
Guys,
So,
you can unmute and ask a question if you have. Do we allow that, Nilesh? Unmute and asking a question?
no, we are normally taking via chats basically.
Okay. There are two more, I believe, which has come. I'll just check.
Are there any more questions, participants?
Because we got somebody saying, Anushri is asking specific guideline for ACL and lateral meniscus repair. See, if it is a lateral meniscus repair, of course, it's a surgeon's call of how to progress on the ACL. What I'm going to be discussing is a specific guideline for an isolated ACLR. And if there is any other concomitant injuries like the meniscus or the ligaments, then of course it will differ. It will differ in the timelines usually, and depending on the patient's status also. Sudhanshu, Nanda, yeah, we can continue the class, but we just have 10 minutes. I'm not going to finish in 10 minutes. So it will be a difficult thing. Nilesh, how do we explain them?
So there's a other way that we can do is you can continue the class, right? And if by chance at 4:30, if the Zoom call is dropped, you can join with the same link again. You can start all over again because the time is for 2 hours. Every time you join, the timing is for 2 hours. So at 4:30, if the call is dropped, so you can join in again to continue the class. That's how it works for this.
Okay, you suggest
I
what do we
don't
do?
know how many slides are there.
Let me just come out of the, let me just check how many have finished. Just a second. I think 30 more slides are there.
Yeah, so I think you will finish by 30,
out of that,
30
I mean,
minutes.
you should say around 20, 24 slides because there'll be a few pictures and videos also.
Yeah. So I think no problem, sir. So Vaibhav, we can continue. No problem with that.
Let's continue.
Yeah, continue. No problem.
Okay. Okay, guys. Thank you for all those questions. What you guys asked, we will try to answer furthermore. So the next is we just checking about how the ACLR rehab has changed over the years. In the 1980s, as we saw, this was the kind of a protocol what was done. 0 to in first 3 weeks, hinge knee brace, 30 to 60 degrees was fixed. CPM within this range of motion, 0 to 90 degrees passively. Total bed bearing was decided accordingly. So this was the way it was addressed in 1980s. So progressive resistance training, still avoiding terminal 30 degrees of extension was there in that 3 to 6 months also. Short arc extension of 90 to 30 degrees was only allowed. Brace off and wean off crutches. So they were different. This was the way it was handled in the 1980s. So when we progressed to the 1990s, it changed a little bit again. and you used a isokinetic evaluation and the KT 1000. Then the sport specific drills were introduced. Prone hangs and the torture pillow was used for the achieving the knee extension, wall slides for the range of motion, heel slides. So all these, so that it kept on changing from decade to decade. And why the change happened basically, there were patients, there were studies which were seen, found non-compliant patients were doing better than the compliant patients, started weight bearing earlier, returned to ADLs and sports earlier, fewer complications such as anterior knee pain and loss of terminal knee extension. So other reasons for the accelerated protocol was, then the change happened because the orthoscopic surgery was introduced, bone, tendon bone, BPTB, and this semitendinous gracilis graft improved fixators. The surgical things improved, introduction of closed chain kinetic exercises, better understanding of the tissue healing was there. And in 2010s, actually, the surgical techniques further changed, and because it's as I said, it's an evolving reconstruction surgery, and it's always changing, and there is a lot of research going on the ACL, which is one of the most commonest injuries. Doing a more anatomical correct placement of the ACL footprint, which helped single bundle and double bundle techniques, going back to the single bundle. The anterolateral ligament repair was there, internal bracing, which has been introduced recently. And that's how the program changed. From rehab side, we had a better understanding of healing process of the graft. The physiotherapy and rehabilitation definitely have improved as we going ahead, and we are addressing the causes of injury also, so that hopefully we don't get back to the re-injury of the ACLR. At the moment, we are going a lot more evidence-based protocol. It's more criteria-driven than time. Better understanding of tissue healing. Load management ensures we load the ligament appropriately to ensure it can cope with the demands of the sport. So the load management is very important in this. So as we keep going, as I said, in the post-op week 1, your aim is to decrease pain and swelling. So we used the acronym POLIS, or the peace and love. CPM use, controversial since no evidence of benefit. So we definitely have discontinued the use of CPM. Gain full range of extension. Definitely no hyperextension, but the full range of extension has to be achieved in the week 1 to 2. Gain at least 90 degrees of flexion before leaving the hospital, which will be helpful in the further rehab. Off to crutches and off of crutches and full weight bearing improves facilitation of VMO function. So earlier the weight bearing, the VMO function or the cordyceps control will be better. So we correct the gait pattern, check for complications like DVT and the various infections. Exercise include, these are the normal exercises. I'm not going to go through the details of the exercises because of the time constraint we have. These are normal exercises, which I'm sure most of you all know about it, but I'll just repeat it, like ankle assist, active range of motion, flexion, SLR, calf stretches, gait, motor control, all these will be there. Do not put anything under the knee post-op, as it leads to loss of terminal extension very quickly. So we have to ensure that it is nothing below the knee. That basically when you do some static exercises or the isometric quadricep exercises, we tend to put the roll of towel or the pillow below the knee, which is not advisable at the moment. Either you keep it above the knee at the thigh or at the heel, which is the most advisable thing today. Note that if MCL involvement, then there might splint knee in some degree of flexion, but it is determined by the surgeon. It depend by the surgeon itself. Early post-op up to 6 weeks, less hands-on and more direction with rehab. Soft tissue therapy we start at this time. Push for passive extension to reduce patellofemoral and the notch problems. Extension antero-posterior glide seems to work best as it is safe for the graft. So we don't do a PA glide. We don't pull the glide into, we don't do an anterior translation of tibia, which is not useful, or which is not advisable to give that kind of a glide if you're talking about manual therapy. We do open chain kinematic exercises, introduce them in the inner range. As I said, we start with the closed chain kinematic work, starting with the 1/4 squat, progressing to half squat. I said the squat progressions, what we do normally. Up to 6 weeks, we need to re-educate the gait, maintain the hip and knee control, use of the foam roller in this, because you would have achieved a good range by now. Exercise include active assisted range of motion on the bike, high seat according to the available knee range, gait loaded SLRs. You give SLRs with resistance, hamstring stretches, rectus femoris stretches, as we saw in the picture earlier, calf stretches, hip work, hip exercises, and definitely proprioception. So these are the banded single leg quarter squats, or the different exercises which are seeing in the video right now. We get into the pool care with walking and open chain kinematic, because you don't want to be there in a complete extension where it might put the graft under some kind of issue. As I said, avoid especially 0 to 30 degrees or 45 degrees, and an increase in effusion also should be checked very consistently, because effusion is the one which we will get to know if the loads are normal or higher. These are the various exercises which you can introduce in an ACL rehab. These are advanced exercises. Basically, possibly you would do this up to or after 6 weeks. Then intermediate post-op up to around 12 weeks. We continue to push extension, gain the full range of motion, continue closed chain kinematic exercises, progress to full squat pain-free, start stationary running in pool, or the hydro exercises, or the aqua exercises what we have. Exercises, passive range of motion, stretching. Gym is allowed at this time. Gym actually is allowed earlier, and we can start progressing onto it. Low seat, leg press, leg curls, lunges, upper body. Start running 8 to 12 weeks if no other intra-articular problem is there. As I said before also, and proprioception training. So this is the example of how we start with the aqua exerciser, about the running, doing some high knees. So this is how, the beauty of the aqua exerciser is the loading can be managed if you have the water up till your chest level. It is your 50 to 70% of body weight is taken off. And if the water is up to your waist level, the body weight which is there is around 40 to 50%. So accordingly, you have to start giving the load with the level of the water. Late post-op, return to sports. We continue with the closed chain kinematic work. We continue the gym exercises, as we call these, to improve the strength and conditioning, strength, power, and burst strength. Continue the stretches as often as, and then add agility, running drills, other agility drills such as jumping, landing, sport-specific cuts and turns, ball dribbling, plyometric drills, and reaction time drills. So these are the examples of. So that's how you do the diagonal running when you talk about return to sport. So initially the straight line running is started, then this kind of a diagonal running. This is the example of bounding, larger step for the run. This is how you introduce when we start beginning to run. So these are the various running drills which we do when we initiate running in an ACL. That's the karaoke or the zebra running, as you call it. So this gives you a little bit of twisting and turning, which is, this is how you do the single leg hops. You start with double leg and then go to single leg. These are the plyometrics. Increase in difficulty with diagonal hopping. Walking lunges, and so forth. This is all preparation for specific preparation for the running work and getting into a sport specific rehab. Do the different stretches also. Stretching your piriformis, stretching your gluteus muscles at different levels. There are a couple of questions in between till you see the video here. Shreya asked me, would the exercises you showed to achieve full passive knee extension be better than prone leg hangs? Prone leg hangs are also as effective, Shreya. I'm not saying these, but I found it better with the exercises, what I have done. I don't do a lot of prone leg hangs because they're a little bit uncomfortable for the patient to be on the edge of the bed and do the knee. So it's better to do a prone knee terminal extension, which is found out to be the best exercise. How you do the prone knee extension, I will try and show it to you because I don't have a picture of it at the moment. I had put it, but it is not there. But it's basically you keep a foam roller or two pillows below your ankle on the anterior side of your ankle. You are in prone position and you lift your knee off the bed. From the anterior surface of the knee is lifted off, so that, and by pressing the ankle down on the pillow or the foam roller which is kept there. So that's one of the best I have found for the knee extension, and it has personally given me in my practice good results. These are the other agility exercises. What we can do on field immediately if you're sure it's an ACL injury, you cannot do anything. You just have to manage it acutely. You definitely protect first. As we said, we saw the acronym peace and love. So protection is the most important thing for the injury not to worsen. So basically, you have to get the player out of the field if you're confirmed that it's a knee injury where he describes you about the pop or the crack, and you see a lot of you see sometimes swelling, you sometimes don't see, and if you have the clinical skills to understand if the Lachman is positive, then definitely don't let them continue and get them off the field. Protect their knee joint, give the compression, the cold compression, and the rest of the peace and love acronym. So these are the various agility work exercises. For the lateral proprioception and strength, you do the sliders on the slide board. Very well to start beginning on the lateral movements. Then the skier jumps. Ensure that the knee is not falling whenever you're doing these exercises. You have to see that the knee is not falling inside the toe line so that the valgus stress is not there. You have to control if somebody has that stress, even in these jumpings also. Single leg 90 degrees turns, you ensure that the knee is over the toes and it's not falling inside the line of the toes. That is very important to gain that control. You go ahead with the plyo work. You start with double leg hops, step ups with a posterior power X band, lateral resistance band. These are the various plyo work which we can do. These can be introduced in a player's training program as a prevention also, because prevention is the most important thing. Triple leg crossover. This is one of the jumps what we used to test the return to sport. Single straight line hops also we do that. This is a hop with complete 180 degrees turn. Box jumps to begin with, single leg box jumps. Box jump and landing over. Box jumps with over double jump. All right, so these are the various ways I would go through to the return to sport and the sport specific exercises routine. This is basically what I'm showing you here is a checklist kind of a thing which you can use on your own. You can visit the kneeresource.com, download this form. It gives you the criteria for progression. It gives you the phases. It gives you the phases of the goal. Like there is this phase 1. The goal is to control pain and effusion, terminal extension as soon as possible, preserve patellofemoral mobility, aim to 130 degrees of flexion within 6 weeks, normal gait and movement patterns. So that's how you do immediate post-operative, what all you'll do for the swelling management, what you'll do for gentle active assisted knee flexion and extension, what all exercises. So it's a very good protocol or the criteria-based protocol what you have, which you can basically tick the boxes that you have completed this, and it's kind of a checklist also for a physio. So you usually can download this from the kneeresource.com and use it in your own clinics in your own way. You can put your own logo there, and it has also given you the earliest time frames for the daily ADLs, kind of driving. If it is driving, if it is a left knee involved, 2 weeks. If it is the right knee involved, it will be 6 weeks. So that's how it is. Breaststroke swimming is not allowed till around 12 weeks of after post reconstruction. Return to full contact sports only after 6 months. So this is what I mean. The criteria, if you see, the wound has to be closed, no pain in phase 1 exercises. All the exercises above which are described, there should be no pain. Minimal synovitis and effusion, normal patellofemoral mobility, tibiofemoral range should be around 120 degrees. Voluntary quadriceps contraction, normal gait and correct movement pattern with exercises. So this is a very good protocol. You can customize it to your own settings and use this. It's the same thing with the phase 2. Again, the criteria for progression is given, goals are given here. Increase the strength, increase the difficulty of neuromuscular and perturbation training, maintain good quality movement patterns, start jogging and sports specific training in this. So the criteria is again, as it is given and written there. It's very well self-explained. I'm not going to go reading about each and everything, but you definitely can use the kneeresource.com website and probably download these protocols from there. That's how it is. So that's about the different 3 phases of the ACL rehab. Yeah, I was talking about the load management. It is very important in these days. We have Tim Gabbett has done a lot of work in the load management area. I've attended his load management courses also, a lot of interaction with him. So it is very important to see if the knee is getting loaded. you have to check the effusion every treatment. So you basically can see this. It's a safe zone if the pain is 0 to 3. If it is 4 to 5, it is acceptable. 6 to 10 is excessive. So pain during exercise should be 0. 10 is worse pain, 0 is no pain. So pain during exercise, if it is below 3, it should always keep to be around below 3, or it should be around 2 or 3, which is a usually good way to progress on the load. So pain and effusion should settle within 48 hours after the exercise routine. So if the pain and effusion is not settling after 48 hours of exercise routine, then possibly you're progressing too fast, or you're giving too much load onto that particular operated ACLR, and you need to control that. You need to take a step back, check yourself, and so after every treatment, before every treatment, after every treatment, you have to check for these signs of effusion and pain to go further on the go further on the loading. Yeah, as I said, it's again about this normal healing reaction of the capsule, including post-op scope goes through the capsule. So there will be post-op effusion there. If it is more than 2+, I mean, don't load that joint. Pain is also more than 2+. Don't load that joint for sure. Listen to the knee. Increase in effusion says we are doing too much. Check before every treatment rehabilitation, as I said. Now that gets us to the return to sport guideline and criteria. So the new latest update on the return to sport guideline and criteria is all about this, and these are the finer more aspects of it. So these are the criteria, what you do. Of course, the surgeon approval is the first. I'm going to share with you basically again a checklist what I have of this all in a Word format. Possibly I will see if I can share that with you all right away, or I'll ask Nilesh to send it to you all. You have to check on the approval by the surgeon to return to sport. Once surgeon gives a go ahead, you need to ensure that the return to sport is in a proper manner. You do check the MRI based graft maturity also. That has also been recommended. The basic measurements are taken. Personality type. So it's basically a very biopsychosocial model of return to sport, and that's what it has to be. It has to be done. So the level of sports activity has to be seen. What is the level of sports? The patient-reported outcome measures have to be seen. The protocol. I'm just going to go out of this thing right now. So we look at the different outcome measures of the ACL RSI. I will share that Word file of the ACL RSI, what you have written to sport injury after that. So then the IKDC scores, the KU score, that have various scores which are available, which you can see. Sport specific scales are there. The adequate range of motion has to be achieved, almost the full range of motion, full extension, as well as knee near to normal to the other limb. You got to check on the KT measurements if it is possible. Balance testing has to be done with kinesthesia and joint position sense testing. It can be done with the Biodex model of kinesthetic or proprioception testing or neuromuscular testing, what we do. Quality of movement tests, stable manual ligament stability, Lachman and pivot shift should be negative when we check. Manual muscle testing with a handheld dynamometer, entire lower extremity. The complete manual muscle testing should be done with a handheld dynamometer, would be more objective and would be more specific. Isotonic strength test, isokinetic strength test, we got to check for the maximum force and peak torque, angle specific torque, rate of force development. We do the kinematic analysis, gait analysis, and running analysis if possible. If you have that equipment, you can do it on a on a 3D motion analysis or a 2D motion analysis. These are the aspects to check if all these are found to be positive and are found to be satisfactory, then the return to sport should be allowed. It is not only about what we talk about, the hop test and the jump test, which was earlier discussed. Only these are the tests which we should look into and decide if the return to sport is possible. We do sport specific testing, we do sports drills, and definitely we carry out prevention programs in the future so that it will help. Then we talk about how we treat a word about ACL injury prevention. When we spoke about the prevention program, the best injury treatment is prevention, and contemporary efforts regarding ACL injury have been embraced this concept. Neuromuscular control is thought to play a very important role in prevention of injuries. So yeah, that's why it's the most modifiable risk factor. It's the most modifiable risk factor, and you basically can work on it. And this working is very, very important. And as you see, as I mentioned earlier, so neuromuscular training, the various drills, what we saw in the videos, these are the ways athlete can get themselves prevented to work on their prevention. Increased dynamic valgus position and abduction loads in the lower extremity have been associated with increased risk of ACL injury. So the dynamic valgus position and the abduction loads, this study was done in female athletes, and it has been, that's why we said there is a lot of valgus load which is always present in females, and that's why they are more vulnerable than the males for the ACLs. But at the same time, there is a study which has come out, giving them the neuromuscular control and preventing and giving a prevention program has helped to reduce their injury levels. Driven by core neuromuscular dysfunction as well as lower limb asymmetry, defined to side-to-side differences in muscle strength and flexibility and recruitment. So you have to ensure that the core neuromuscular dysfunction is not there. There is no lower limb asymmetry. There is no side-to-side difference in muscle strength, flexibility, and the recruitment patterns. This will lead to the dynamic valgus positioning and abduction loads, which can be vulnerable for an ACL injury in the female athletes. Neuromuscular training facilitates adaptations which improve pre and mid-stance neuromuscular activation patterns, which decrease the joint motion and protect the ACL from high impulse loads sustained during performance. Emphasis should be in the prevention program on the developing the posterior chain muscle group strengthening, such as the glute maximus, medius, minimus, hamstrings, to reduce the load on the ACL. Multiple studies conclude also you can do these movement assessments even as we talked about in the return to sport program. You do the where we just let me just go back to that slide. We talked about the kinematic analysis and the gait analysis. When we do the kinematic analysis of movement or the jump test, basically, like the Kinect, there's a Microsoft Kinect system, is a very feasible dynamic valgus screening, drop vertical jump screening to identify individuals at a risk of ACL injury. So if those kinematics are present of the valgus when you screen them, then they will be vulnerable for an ACL injury. So you have to do a targeted intervention for that, where you do the enhance the neuromuscular training, enhance the strength, and accordingly come back to the accordingly give these interventions in their normal training routine, so that it will help them to prevent an ACL injury. There are recent evidences a little bit which is coming off. There's a real-time biofeedback integrated into neuromuscular training, reduces high-risk knee biomechanics and increased functional brain connectivity. A preliminary longitudinal investigation has been done, but still not out. So we don't know exactly the outcomes of this, but there are efforts towards prevention of an ACL, because that's the best treatment. And these kind of things where it gives you the biofeedback with the integrated neuromuscular training will will definitely reduce the high risk biomechanics and increase the brain connectivity. Then to improve the strength, there are various new devices like the BFR, which have come out, which are the BFR cuffs. So blood flow restriction techniques, which can be also used. They are also being studied and how can use them. 6 key aspects which are often neglected after ACLR, which may impact a player's outcome. So these are the 6 outcomes which was described by Vaibhav. You should note these down, and deficits in explosive neuromuscular performance are the key, which if there are deficits, they will be vulnerable to a re-injury. So you have to ensure that these are not there. Deficits in sport-specific movement quality. You should not allow the player, if his movement quality in the sport is not exactly the way it has to be. Inability to tolerate fatigue, a lack of sport-specific on-field rehabilitation before return to play, insufficient intensity and volume of training prior to return to play. There should be adequate training. I'm not saying the training and the intensity and the volume has to be more. So that will go into a lot of training load. But at the same time, it has to be sufficient. It should not be insufficient, but it should be sufficient enough so that it will give them the stresses, the new ligament, the stresses, so that they can reproduce it when they are in an actual action of the sport. A lack of focus on restoring the player's sport-specific fitness profile is a key aspect. Again, these are the 6 key aspects which may result in a different outcome. So you have to not neglect these 6 things to ensure a good return to sport. Yeah, I want to just put a word lastly into the, because of the current situation and the scenario of the COVID, we are not able to attend every patient in person. So there was a study done on that. Physiotherapist-led rehabilitation is a key ingredient to a positive long-term outcomes following ACLR. But how much face-to-face rehabilitation is required to achieve satisfactory outcome? A pilot study was done who have minimally attended physiotherapy in first 6 months following anterior cruciate ligament reconstruction achieved the similar outcomes at 12 months post-op of those who attended regularly. So that's the difference. So if you ultimately, I would suggest, if it is not possible to see your particular patients in person, you should follow these advice, empower them to take the ownership of the ACL rehab, educate them, give them confidence, motivate them, give them the great exercise advice, give them a good plan, give them ideas of how to progress their exercises or regress them if needed, educate them about the swelling, about the pain. If these are the things which are hampering their progress in the rehabilitation, they need to take a step back. Give them reassurance if they are getting sore. Give them a confidence to do things without you holding their hands. It is not necessarily that you are required to be present in person, but without it remotely also you will be able to do this. And this has been proved from a study as we saw. So that's about my ACL rehab presentation. Thank you very much for listening to me, guys. It was nice of you all to attend it. Possibly a few of them had dropped out probably because we extended the time. But there are these questions which I will definitely answer. Nilesh?
Thank you so much. It's Pallavi here from SNFS team, sir.
Yeah.
Hi. So it was a wonderful session. Thank you so much.
Yeah.
For the session. Yeah, I think we have a few questions over here.
Yeah, I'm just seeing those questions right away.
All right, all right.
There is a website or a video on YouTube with all the ply and power drills that you showed us, or us to refer to in the future. These I have driven. I mean, you'll have to search on them. I mean, specifically, I don't have anything known as such. But yes, definitely there are all available onto the internet. Okay, thank you, Priya. Thank you, Abhishek.